and we're including cellular regulation and sexuality. And so we put elimination, the concept of elimination is the excretion of waste products. So we're going to be talking about that. The different exemplars that fall under that. Okay? All right. If you can't hear me, I'm going to stay up front because I guess my voice is not projecting. So, let's raise your hand if you can hear me, slow down, or whatever. Okay? All right, so our first exemplar is BPH. I know you've seen some of your patients come in with this on their history. Or maybe you've even worked with patients that have had prostate surgery. See, I always want to walk this way, so put a leash on me. What's that? That road's troublemakers, aren't they? Maybe I should stand over here with them. Okay, so benign prostatic hypertrophy or hyperplasia. It can also be called. And it's changes in the prostate gland, and this is a normal occurrence that happens with age. The prostate is an accessory gland of the male reproductive system. And what its purpose in life is, or as one of our organs, is to secrete a milky alkaline fluid that adds bulk to the semen. So the prostate is an accessory gland of the male reproductive system. It secretes a milky alkaline fluid that adds bulk to the semen and enhances sperm movement, and one other thing, and neutralizes, I'll read this again, acidic vaginal secretions. So it secretes an alkaline fluid that adds bulk to the semen, enhances sperm movement, and neutralizes acidic vaginal secretions. Okay? So, like I said, they're inadvertently called both hypertrophy or hyperplasia. So the benign prostatic hypertrophy or hyperplasia, or BPH, is nearly universal condition in older men. Typically, you start to see this happening kind of at a young age, 51 to 60. Looks young to me anyway. And in 90% of men over 80. So sooner or later, guys, your prostate's probably going to be large. Let's not talk about your prostates.
We say 51 to 60, and what about
51 to 60, it starts to occur, and then in 90% of men over 80 have this. It's the most common benign neoplasm in men. It's the most common benign neoplasm in men. It is highest in African American men and lowest in Japanese men. So, makes you wonder, is it a diet kind of thing? The exact cause is unclear, but it is most likely the result of a combination of just the aging process and the male hormones or androgens that are present in the prostate. And I'll read this again. And they cause the glandular units of the prostate to undergo nodular tissue hyperplasia, which is an increase in the number of cells. So it is the exact cause is unclear, and it is most likely the combination of aging and androgens that are present in the prostate that cause the glandular units of the prostate to undergo nodular tissue hyperplasia. And that's simply an increase in the number of cells. So, as the prostate gland enlarges, it extends upward into the bladder. As the prostate gland enlarges, it extends upward into the bladder and inward, causing bladder outlet obstruction. So, I'll do my wonderful drawing for you here. So, we've got our bladder. And we've got our urethra. And our little prostate is right there. So, as it enlarges, it kind of goes up here, and it goes in here. Not that much, hopefully. Here we got a major emergency, but okay. We'll talk about that.
Full bladder.
I'm sorry? I'm going to put him in the corner. What did you say? The urethra narrows?
Yeah, it causes the urethra to narrow.
Right.
It enlarges.
Right.
And what does it do to the bladder, though? It
Okay.
causes it
Let's
to-
talk about that. Okay. Alrighty. So, as the prostate gland enlarges, it extends upward into the bladder and inward, causing the bladder outlet obstruction, because you got your bladder trying to push that urine through, and it can't get through. It's got this little narrow area to go through. So the detrusor, or bladder muscle thickens. Detrusor, sorry, I'm tongue-tied to that. Okay, so the detrusor muscle thickens to help urine push past that enlarged prostate. Okay? So you got this, your bladder muscles working, trying to get that urine down through there. Even with the bladder change, you'd think it'd make the bladder a little stronger, but, you know, you can overuse a muscle, and that's what happens. So even with the bladder muscle change, the patient has increased residual urine, or stasis, and chronic urinary retention. So, you know, it works hard to get that urine through, but eventually it just kind of gets tired out, and of course if you got the prostate growing and putting more pressure, then it's going to make it worse. So they tend to have chronic urinary retention. They also have increased volume of residual urine often causes overflow or urinary incontinence. So urine leaks around the enlarged prostate, causing dribbling. So a lot of these patients will come in complaining of dribbling and never feeling like they're totally emptying their bladders. What happens with urine that's not moving through? What would we see a lot of time? Infection. So urinary stasis can lead to urinary tract infections. Also, bladder calculi. We're going to talk about that today too. And calculi are stones. So stasis of urine can cause bladder stones and also urinary tract infections. So many times these patients come in with a urinary tract infection also. Some patients' prostates become so large that the man can't void. This is an acute, or this is a true emergency. And they call this acute urinary retention. or AUR. And again, this is pretty emergent that you go in and fix this. Because also what happens with this, urinary retention, may result in backing up of urine and causes a gradual dilation of the ureters. So then you start getting renal involvement. Get my picture right. Okay, I got the ureters. So then it starts backing up in the ureters. Okay. And this causes hydro, which is our water, right? Ureter. So these ureters dilate excessively. The kidneys, then it backs up a little further into the kidney. And it starts to get fluid. And so you have hydro, again, water, right? Nephrosis. If this BPH is not treated, these problems can lead to what, you think?
Kidney failure.
Chronic kidney disease. So it's something we need to fix. Okay, here's a good picture. So on the right, we have our nice normal kidney and ureter and bladder and prostate. And this is our prostate that's starting to grow. It's starting to push on that ureter, start to push up in the bladder. This causes urinary retention. And then we get reflux up in the ureter. Bladder becomes hyperirritability, hypertrophy. In other words, it gets a little larger, less effective muscle, and even get some little diverticuli in it. So we talked about the hydroureter and the hydronephrosis that can happen. Okay. So, assessment. So we're going to ask the patient about their urinary pattern and symptoms. We're going to check this patient for bladder distension and prostate enlargement. So we want to pay close attention to the urinary patterns and lower urinary tract symptoms, or LUTS, lower urinary tract symptoms. And they have an assessment tool that they can use. And it's called the International Prostate Symptom Score, or International Prostate Symptom Score. With which this also incorporates the American Urological Association Symptom Index. You don't have to know that. There's 7 questions that we ask the patient. And then we also, for this particular assessment tool, we add the question, what effect has the patient's urinary symptoms had on the quality of life? And this is in your book you can look at. I'm sorry?
Would that be on the test?
Maybe. Okay, so our lower urinary tract symptoms can be, we're going to ask them about frequency, urgency, number of times the patient is awakened during the night to void, or nocturia, any hesitancy, weak stream. That makes sense, doesn't it? Sensation of incomplete bladder emptying. Straining to begin urination. And post-void dribbling or leaking. Hematuria, which is blood in the urine, right, is very commonly seen with patients with BPH. So the healthcare provider, or hospitalist, or doctor in the hospital, will do what's called a digital rectal exam. And this is because the prostate is so close to the rectal wall that it can be felt through the rectum. And what the examiner is feeling for is the prostate size and consistency. With BPH, or benign prostatic hypertrophy, the prostate will present uniformly, it will feel uniform in shape, elastic, non-tender, but enlarged. So with BPH, the prostate is in uniform shape, elastic, non-tender, enlargement. Okay? Difference with cancer, which we're going to be talking about a little bit later in more detail. Cancer of the prostate feels like a stony, hard nodule. So you can see why these digital rectal exams are very important to be done. And again, 50. Pardon me? The cancer of the prostate, is that what you want? Okay. The cancer of the prostate feels more like a stony, hard nodule. Okay? And the ripe old age of 50 is when everything starts falling apart. We've got to go, we've got to encourage our guys to go have their prostate checked. Yearly, yes. And of course, if there's an enlargement, you're going to be seeing your doctor more often and getting medications, but definitely want to keep tabs on it. Labs we want to check. UA and CNS. Why would we want to do that? We've done talked about that. CBC, what would we be looking for on the CBC?
Infection.
Right. What's going to tell us infection?
White blood.
Elevated white count. What else do we want to look at?
Sed rate.
Okay. Sed rate could be a good thing. What else? What else do we have going on with the prostate? Okay. BUN and creatinine. Yep. What about with the CBC? Thank you. Red blood cells, H and H. See how anemic they are, or if they're anemic, right? Because they're losing blood, typically. As Erin said, BUN and creatinine to evaluate renal function. And the good old PSA, which is prostate-specific antigen. PSA, or prostate-specific antigen. And serum acid phosphatase level. Because if prostate cancer, which we want to rule out, right? That's big, well, we want to decide which it is, but definitely rule that out. Both of those will be elevated. If it's prostate cancer, the PSA, or the prostate-specific antigen, and the serum acid phosphatase will be elevated. During the prostate exam, the prostate can be massaged, and sometimes some prostate fluid can be extracted. And so what they can do is they can send that fluid down to rule out prostatitis, which is what?
Inflammation of the prostate.
Inflammation of the prostate. So an infection of the prostate, then we would treat it differently. So the DRE, digital rectal exam, is the go-to procedure we do for this. We can also do, if we're still trying to rule out prostate cancer, we can do a trans-abdominal ultrasound or a transrectal ultrasound to get a better view. Sure.
I have a QA and CNS. I have a QA and urinalysis, but what lab is CNS?
What lab is CNS?
CNS.
You know.
Culture and sensitivity.
Culture and sensitivity.
Oh, I thought you were saying CN, like
Yeah.
NN, like.
Yeah, kind of a slangy kind of way to say it. We say it so fast it sounds like CNS. It sounds like a C and ACS. Sorry. Yep. I'm glad you asked.
Come on, Candy.
I was gonna look it up, man.
You wouldn't have found that, would you? CNS? That might be a TV station. Okay, sorry about that. Thank you for asking. Thank you for asking. I was like, I know you guys know what CNS is. CNS. Okay, so are we good? Let's see if we need to go back further. Wow. Some other questions? I'm sorry about that. Okay, are we good? We good? Sorry, I didn't do it there. My mistake. Okay. Okay, so we're good on all the other ones? All right. Okay. All right. Okay. Non-surgical management. And I know a lot of you have given these medications in the hospital, since it's so common in our older men. Proscar or Avodart. I know you've seen those, given those. These are androgen inhibitors because we think that that is part of the problem. The hormones are making the prostate enlarge. So the androgen inhibitors shrink the prostate gland and improve urine flow is our goal. Unfortunately, the side effects of this medication are impotence and decreased libido. Then we look at alpha blocking agents such as Hitrin, Cardura, and Flomax. And I always tell students to remember Flomax. We want it to flow to max, right? So that's an easy one for me to remember what that's for. I'm sorry?
I say maximum flow.
Maximum flow, yes. We want maximum flow. The alpha adrenergic receptors in the prostatic smooth muscle respond to alpha-1 selective blocking agents. I'll read that again. That's a big bunch of stuff there. So the alpha adrenergic receptors in the prostatic smooth muscle respond to alpha-1 selective blocking agents. Okay. So the alpha adrenergic, that's that big old word, receptors in the prostatic smooth muscle respond to alpha-1 selective blocking agent. Maybe one more time. The alpha adrenergic receptors in the prostatic smooth muscle, in other words, the alpha adrenergic receptors in the prostate smooth muscle respond to the alpha-1 selective blocking agents, Flomax. Flomax, these drugs relax the smooth muscles in the prostate gland, creating less urinary resistance and improved urinary flow. So that's the big part you need to remember. These drugs relax the smooth muscles in the prostate, so they'll quit putting so much pressure on that poor urethra, creating less urinary resistance and improved urinary flow. They found that the most effective drug therapy approach for many patients is a combination of both of these. So hit them with both of these. You'll see patients on both of these. Now there are some herbal remedies. You know, everybody likes those herbal remedies, which we need to be cautious of, right, with our patients and teach them. One of them is saw palmetto extract. This seems to be a popular one. So saw, S-A-W, palmetto extract. So we need to ask our patients if they're on this because, you know, Joe at the sandwich shop said this really works good for him. You know, that's how people treat themselves typically because so-and-so told them to take it. But anyway, the thought is many men use this plant extract to help manage their urinary symptoms. But we need to tell our patients scientific evidence has not proven that it's useful. Okay? But they need to discuss it with their healthcare provider. So they make sure that they know that they're on it or taking that. Okay? Other interventions that may reduce obstructive symptoms include those that cause the release of prostatic fluid, such as prostatic massage and frequent sexual intercourse.
That's right.
Kind of like if you don't use it, you lose it, I guess. So it's better, you know, to keep an active sex life because it keeps your prostate working better. You can use that excuse now, guys. Okay. What we want to do is teach our patients to avoid drinking large amounts of fluid in a short time. You don't want to overload the bladder and then that bladder's having to work overtime to try to get that urine through. So not take large amounts of fluid in a short time. To avoid alcohol, because it'll make you have to go to the bathroom too. It's a diuretic, right? And then diuretics. So, you know, patients that are on diuretics who have this need to talk to their doctor about it and see if they can be on a different medication. Caffeine, also a diuretic. And we need to instruct our patients to void as soon as they feel the urge, not to wait. So to void as soon as they feel the urge to prevent over-distension of the bladder, which may result in loss of the detrusor, which is our what? Muscle, bladder muscle. Another thing we need to teach our patients is to avoid any drugs that cause urinary retention. These are anticholinergics, the seemingly innocent antihistamines and decongestants. So we want to teach them to avoid anticholinergics, antihistamines, and decongestants because they cause urinary retention. And you don't want to take diuretics, and that might be a tough one to call. You know, if they need it for other reasons, I don't know how you don't want to tell your patient not to take medicine that their doctor has prescribed, but talk to their doctor about it. Because again, you know how diuretics work. You give it, bam, it's right to the bladder, and you've got a full bladder. So it's not a great thing for them. Okay. We're close to the end of ours. Okay, are we good? Keep going a couple more? Okay. All right. So, criteria that indicate the need for surgery. Remember we talked about it? The acute urinary retention. If someone can't urinate, we've got to do something, right? Because we're going to cause major damage to the kidneys. So, that is a criteria for emergent surgery. Chronic urinary tract infections, they just keep getting them and getting them and getting them. There are people that need to have surgery. Chronic urinary tract infections secondary to the residual urine in the bladder. Hematuria, if they're bleeding quite a bit, you see that hemoglobin, hematocrit, RBCs dropping, definitely going to need it, need surgery. And as we talked about, hydronephrosis. We don't want that to happen. That's gonna be hard on our kidneys or damage our kidneys. So the TURP, we call it for short, or the transurethral resection of the prostate, is our go-to surgery. It is the most popular surgery still to this day for an enlarged prostate. What they do is, and there's some pictures of some other things here, but this is what we're going to look at right here. What they do is they put, make sure I call it the right thing. Okay, well they rectoscope. They put a rectoscope through the urethra, and that's very similar to a cystoscope. But the rectoscope has a cutting and cauterizing loop. So they put this through the urethra, and the enlarged portion of the prostate gland is then resected into small pieces, or prostate chips. So they go up the urethra, and you know, the prostate secretes this milky solution, so they go through those ducts and they cut portions of the prostate and either extract them or they get to the bladder and then they get flushed out. After a TURP, or transurethral resection of the prostate, all patients will have an indwelling catheter for at least a day. We need to let them know that they will feel the urge to void while the catheter is in place, because what we're going to do, you know, we have a balloon on the end of the catheter. We're going to fill, it's going to be filled more so than the 10 cc's. I'm not sure if it's 20, 30, thank you, 30 cc's, and they're going to put traction on that. You know, we usually bring it down just a little bit, but if somebody's really complaining, then we might move it up a little bit. I don't know if you've ever seen that done. Okay. But we want that traction because that's going to help keep this from hopefully bleeding. So you're putting traction on it. So we need to let our patients know that you're going to feel like you need to urinate, but don't try to urinate around the catheter. Okay? Try to relax. So we need to give them medications so they don't do that. We will see, we need to tell our patients also that the urine's going to be blood tinged. Makes sense, doesn't it? And so we're monitoring that. And they may pass small clots. So it may be blood tinged. And we'll talk about what we don't want to see. Okay? Okay. Disadvantage of a TURP is that you can only get so many little pieces through that little duct. And many times this nasty little creature will grow back. So sometimes it has to be repeated. And then they're having problems again. Requiring more TURPs. with this, as you can imagine, there is a risk for urethral trauma. And that can cause urethral strictures, scar tissue. And then that would have to be another surgery. So, not ideal, but it seems to be the go-to procedure. Okay, you guys need a break? Okay, all right. We don't see these as much anymore, and Adam was talking. Would you share about what you saw with your turf? The question was, how do they get those pieces out? And Adam has seen that, so he had a great explanation of it.
It's connected to the tube that goes in through the urethra is a irrigation tube. So it injects normal saline in constantly and then drains back out into a little canister. And so as they're cauterizing it to get the pieces off, it just flushes right out, so that they don't have to worry about irrigating afterwards. They do it during.
So they improved that. I wonder why we didn't see this as often. Have any of you guys seen this? In clinical, have you seen? We used to see this a lot. You have seen it?
Turf or just continuous
The
blood?
continuous
I've
bladder.
had somebody with it twice here in Clinical.
Wow. Okay, so they're still using it.
We see it. Every turf that's done on our floor has continuous bladder.
Oh, really?
Every
I
person.
have not seen that. Okay, so it's pretty standard procedure. Okay. All right, great. All right, so talking a little bit more about it, it's an extensive, you want to have extensive cath care with the continuous bladder irrigation for a CBI. The MD will use retraction 3-way catheter, and this is to decrease the bleeding. Using the traction, the man must keep his legs straight while the traction is applied. So again, they usually tape it. Do you guys tape it to the abdomen or the thigh? The thigh, okay. So again, they're going to have the urge to void with this continuous bladder irrigation. But it's due to the large balloon, as we talked about, with just a normal Foley. And again, we want to encourage them not to void around the catheter. And I didn't mention this earlier, but if they try to void around the catheter, it'll cause bladder spasms. And that can be painful also. So with a patient who's having continuous bladder irrigation and they are complaining of bladder spasms, what would be the first thing you do? Joey, you can't answer this because I know you know. What would be the first?
Would it be the position of legs?
Stop it for me. I wouldn't touch the catheter because that's where the doctor wants it.
Would you stop it using the fluids for that?
You can, and we'll talk a little bit more because you're right. With these irrigations, you speed them up and you slow them down. Why would you speed it up or slow it down? Do you know? Joey can't answer this.
The amount of blood.
Right. Because we want the irrigation fluid and urine to look pale red. So, it's kind of like a nursing judgment. Okay, that's looking a little darker. I'm going to up the irrigation. Okay. But what else can happen? And we're probably going to do something else. We're going to talk about something else a little bit later. But what do you think if the urine looked good, the amount was appropriate that was in the bag, but they are just having unrelieved bladder spasms? What do you think? Yeah, that'd be good. Bladder scan. I wouldn't clamp off the catheter. What can be a problem, you think? Because what's happening is the solution's going in, right, rinsing and coming out. So it could be a clot, right? But it could be as simple as what with the tubing? Kinked. It could simply be a kink in the tubing. Actually, there isn't any drainage. I said it was appropriate, but really, you would notice that as much as gone in hasn't come out. So what's going on? The first thing you're going to do is look for a kink in the tubing, and you don't want that to happen, right? Because you don't want to fill up with irrigation solution. Okay. So the first thing you're going to do is inspect for an obstruction. It could be external kinks, and you're right, it could be internal, like a blood clot. what you're going to see is decreased output. Some people have more bladder spasms than others, so there'll be some antispasmodics ordered, maybe like Bentyl. So a continuous bladder irrigation with normal saline, you want to make sure that the catheter is kept clear of obstructions. So that's why you're regulating that rate of irrigation. And we want it to be just slightly pink. Is that what you guys do too, Joey? Slightly pink? You want to, you of course, are monitoring this very closely to make sure that it's just not frank blood, very bloody. That would be a bad thing, right? And what can happen with this normal saline going in, going in, going in? What do you think could happen with the person? Okay. Well, what goes to sodium?
Water.
Okay.
Dehydration.
And actually, it can cause hyponatremia. And anemia, we're watching. So this you will see. Anything to add, Joey, about anything you've seen or experienced with this? So you probably remember your math question last year about how to figure out I&O, and how much urine is actually in there. So you have to know how many bags to come, right? And that's all irrigation. So you're going to subtract that irrigation from your output, and then what's left is your actual urine. When the catheter is removed, we want to teach our patients that they're going to experience some burning on urination, and that's normal. They're going to experience some frequency and dribbling and maybe a little leakage. And we need to reassure him that these symptoms are normal and should decrease. We also want to let our patients know that they may also pass clots and tissue for the first several days, so they're not freaking out when they see that happening. We also want our patient to increase their fluid to at least 2,000 to 2,500 milliliters per day, so we can really flush that bladder out. And of course, if it's not contraindicated, because they have congestive heart failure or something like that. And drinking lots of fluid, of course, helps with dysuria, which is discomfort with urination, and helps keep the urine clear once this comes out. By the time these guys go home, by the time they are discharged, which is usually about 2 days, they should be voiding about 150 to 200 milliliters. And in 2 days, it should be clear every 3 to 4 hours. When they're discharged, pain should be minimal. And usually they don't even need any narcotics, analgesics. Oh, hang on. No, sorry. Analgesics may not be required, but they may still be required. They void 150 to 200. Should be clear yellow urine every 3 to 4 hours.
You said they should not get a lot of pain.
They should not. They should just have minimal pain. Yes. Void every 3 to 4 hours. Yes. 150. There. Okay. So, of course, the number one risk factor for this is severe bleeding or hemorrhage. We're wanting to check that urinary output every 2 hours, vitals every 4 hours. And we're going to notify the doctor if we see bright red drainage that doesn't clear with increasing the irrigation. Ketchup-like urine, I'd really be freaking out, I think. increased amount of clots. Joey, what'd you say?
She said I'm going to ketchup. That's not a good way to
I know.
compare that.
Just ruined it for you, didn't we? And of course, significant changes in vital signs, and I think we've hit on that a lot today about what you see with hemorrhage, right? And a change in the hemoglobin hematocrit. So we want to be watching those carefully and call the doctor if we need to. So the most critical time for this to happen, severe bleeding or hemorrhage, is most commonly in the first 24 hours. Okay. Client education or guide or care after a TERP. Again, drink plenty of fluids. Use alcohol, caffeine, beverages, spicy foods in moderation, and avoid overstimulation of the bladder. To avoid overstimulation of the bladder. Don't want to work it too hard and cause bleeding to start up again. If the patient finds that the urine becomes bloody at home, they need to rest quietly and increase their fluid intake. They need to avoid strenuous activities such as driving and working during the first 2 to 3 weeks after surgery. And definitely follow up with your doctor. So we want to also teach them about possible but uncommon complications of this. Always a risk for infection. So we want them to monitor their temperature and that kind of thing. And incontinence sometimes. We want to assure them that sexual function should not be affected after this surgery. But what will happen is called retrograde ejaculation. Can happen, I should say. Retrograde ejaculation.
Which is what?
And that is where most of the semen flows backwards into the bladder. So that only a small amount is ejaculated from the penis. So when they're sexually active, there will not be a lot of semen because most of it goes backwards.
That's a side effect of blood mics too.
I did not know that. Well, I know it can cause impotence.
Well, it relaxes the prostate. So
Okay.
when you ejaculate, it goes back into the
Okay. Very good.
And it works too. I've taken Flomax, that's how I know.
Okay. Okay.
Take Flomax for kidney stones.
Okay, well that makes sense too. Great. Well, you can talk to us about kidney stones when we get to that part.
You don't want one.
I know, that's what I've heard. That's what I've heard. And we are in the belt. Yeah. Yes. Yes, and it doesn't hurt anything. So they don't need to be alarmed that there's just not as much semen when they do ejaculate.
Kidney stones don't wash.
They may have a temporary loss of control of urination or dribbling of urine, but we need to reassure them usually these symptoms are temporary. And what can these guys do? Kegels. Miss Beaver's famous Kegels. Guys can do them too. Yeah. So we want to have them contract and relax their sphincters frequently to establish that urinary control. They found that starting and stopping your urine flow is really not a good idea because you might have urine going up and causing urinary tract issues. But if you can figure out where that area is, that's a good way to help with that. Okay. What's that? Yep. It's all. Maybe I put it in the wrong place. See, I'm mixing up my
hormones.
Okay, yes, I should have. Well, stones develop in different parts of the urinary system. So we have ureteral lithiasis, which is stones in the urinary tract no, that's all that means. Stones in the urinary tract. Urolithiasis. Then we have nephrolithiasis, which is stones in the kidney. And uterolithiasis, which is stones in the ureter. So lithiasis. Nephrolithiasis. And uretolithiasis. Okay? All right. And stones are made up of different compounds, but the most common is calcium stone. So urologic stones are caused by many disorders. However, the exact mechanism of stone formation is not entirely understood. So we all excrete crystals in our urine, but fewer than 10% form stone. Like I said, most stones contain calcium as even part of the stone complex. Sometimes other compounds accumulate on these calcium stones. High urine acidity, as with uric acid and cysteine stones. So high urine acidity causes uric acid stones and cysteine stones. In an alkaline environment, alkalinity, calcium phosphate stones, and struvite stones develop.
Phosphate what?
Struvite stones. So high urine acidity, we have uric acid stones and cysteine stones. And high alkalinity, we have calcium phosphate and struvite stones. And some medications contribute to stone formation. And I'm not going to expect you guys to know those. Just know that part. One metabolic problem, and we'll talk more about that in a second, causes stone formation. One metabolic, so they feel like it's more of metabolic problems that cause stone formation. So one metabolic problem causing stone formation begins with excessive amounts of calcium that's absorbed through the intestinal tract. And this is a metabolic disorder, okay? That shouldn't be happening. So metabolic problem that adds to or causes stone formation is when excessive amounts of calcium are absorbed through the intestinal tract. This is the most common cause of hypercalciuria. What happens is as the blood circulates through the kidneys, the excess calcium is filtered into the urine. So as the blood circulates through the kidneys, the excess calcium is filtered into the urine, causing supersaturation of calcium in the urine. What do we mean by supersaturation? Lots of it. Bunch of it. If fluid intake is poor, such as when a patient is dehydrated. I know I saw a guy come in with a kidney stone, and it had been like 90 degrees the whole week, and he's in construction. And he'd had them before. Was yours in the summer, Joey? Yeah. So dehydration is a big no-no with this, because you don't want those crystals sitting in there being super saturated in the bladder or wherever. Okay. So, if fluid intake is poor, such as when a patient is dehydrated, supersaturation is more likely to occur, and the risk of calcium combining with another compound to form a larger molecule increases. I'll say it again. Okay. If fluid intake is poor, such as when a patient is dehydrated, supersaturation, which is having a lot, right, in the renal system, is more likely to occur, and the risk of calcium combining with another compound to form a larger molecule increases.
What's the other compound?
It could be any of those. Okay.
I got a picture of it.
Oh.
Google it.
Of you?
No,
Where'd you get it?
patient sent it to me.
Of a stone?
Yeah,
Okay.
but it's just a picture of it in it.
How big was it? Was it?
Yeah.
One stone?
Oh,
Oh, wow. Well, I'll draw a picture of it for everybody. Oh, that did not pass, obviously.
it had to be certain.
Yeah, and if they're big, and we'll talk a little bit more about that, but it was like, can you imagine trying to pass something like that? Oh, so there are stones that are too big to be passed. We'll talk about that. Okay, guys, we're almost done. Hang in there, hang in there. Have you ever seen a staghorn stone? Joey, have you ever seen this? A patient have one of these? Okay. That is the whole kidney on that side. Obviously, that has to be surgically removed. Yeah. So this is a good picture of what can happen. So as long as they're up here in the pelvis of the kidney, you're all right. You know, we're still getting urine through. It's no problem. It's when they start to try to move down the ureter and they get stuck. Then we got a problem, right? So all this urine can't get through. We start backing up, and that's where your pain comes from. So you can have stones in the ureter or stones in the bladder. So a lot of people can pass stones. It's painful, but most people can pass stones. They get to the bladder, they get a little relief, and then they have to get them through the urethra. So it's not over till it's over, so to speak. But anyway, that is a large stone. That actually is not painful because it's not moving. It's not going anywhere. You would think that stone right there would be very painful. Now it's doing a number on the kidney there, but it's not really painful. So stones that form in the kidney and then pass into the ureter often lodge in areas where the ureter bends or slightly changes shape. When the stone occludes the ureter and blocks urine flow, the ureter dilates and we end up with hydroureter. Ureter full of urine. So, our causes, as we kind of hit on. Dehydration. So, you never want to have a kidney stone. Drink, 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 drink. Lots of water. Coffee, well, yeah, probably. Fluids in general, I guess. So some of the causes are dehydration, infection, obstruction. But as we talked about, that stagnant urine just sitting there can cause stones to start manufacturing, so to speak. And metabolic factors. The cause of urolithiasis is actually unknown. At least 90% of patients who form stones have a metabolic risk factor. So at least 90% of the patients who form stones have a metabolic risk factor. Dehydration, of course, slows urine flow. Again, results in that supersaturation of the urine with the particular element, most of the time calcium, that leads to crystallization and later becomes a stone. Now, misconception is, oh, well, you don't want to drink too much milk. That is a misconception. You have to have a metabolic dysfunction for calcium stones to be. No, what calcium? Yeah, milk products. So a diet high in calcium is not believed to cause stones unless there's a metabolic problem or kidney tubule defect already exists. So a diet high in calcium is not believed to cause stones unless a metabolic problem or kidney tubule defect already exists. And actually, data suggests that a normal calcium diet that is relatively low in animal protein, so data suggests that a normal calcium diet that is relatively low in animal protein, sodium, or both may help prevent stones formation. So data suggests that a normal calcium diet that is relatively low in animal protein, that on red meat, sodium, or both may help prevent stone formation. So urinary stasis again, urinary retention, immobility, and dehydration all increase the risk for stones to form. Urinary stasis, urinary retention, immobility, because our immobile patients have higher calcium, don't they? And dehydration all increase the risk of stones to form. The incidence of stone disease is high and varies with geographic location and race. Higher in the southeastern U.S. Yes. Japan and Western Europe. So it's higher in the southeastern U.S. They call it the Stone Belt. Is that what they call it? The what? Yeah, they call it the Bible Belt. We've got a lot of nicknames for us. So southeastern U.S., Japan, and Western Europe. Gender. Calcium stones are more common in men than in women. Calcium stones are more common in men than in women and tend to occur in young adults or during early middle adulthood. So calcium stones are more common in men than in women and tend to occur in young adults or during early middle adulthood. So it's a young person's issue. It's more often in younger adults, as I just said, than older, and more common among white people. a family history has a higher reoccurrence in patients than those who had first occurrence by, wait a minute, and those who had, I'll say that again, first occurrence by age 25. So there's a higher incidence, reoccurrence, in patients with a family history and those who had first occurrence by age 25. Joey, you meet those credentials? Didn't you have 2, you said?
Yes.
Do you have them in your family too?
Not really.
Okay. You're the only one?
I have 1 or 2, but
Okay. Anybody else have any? I mean, we should have more people in here. Anybody in your family?
Mom, brother, sister.
Okay, mom, brother, sister. Great gene, pass on, huh? As many as we. Anybody else? Stories? Were you able to pass it on your own?
I had 12 the last scan, so I've had about 8.
They're
and
sitting?
surgery twice.
Okay. Wow. We're talking about surgery. Okay. Did you have to have surgery, or were you able to pass them on your own?
oh, thanks.
Good. What a man. Not that you weren't, but you got
I was a baby.
Okay. Let's see how many more we have. Okay, well, we do have some more on this. You want to just break? We were talking about kidney stones. And the biggest assessment finding you will have is severe pain. So this severe pain with kidney stones is also called renal colic. Severe pain that comes along with kidney stones is renal colic. Flank pain in the back here suggests that the stone is in the kidney or the upper ureter. Flank pain that extends towards the abdomen or the scrotum and testes and or vulva, well, not and or, or vulva, suggests stones are in the ureters or bladder.
You said it again?
Yeah.
Start with flank pain.
Flank pain suggests the stone is in the kidney or upper ureter. Okay. Flank pain that extends towards the abdomen or the scrotum and testes in a male or vulva in a female suggests that the stones are in the ureters or bladder.
Okay, can you repeat the last part? Sorry, about the men.
Flank pain that extends towards the abdomen or to the scrotum and testes or vulva in a woman suggests that the stones are in the ureters or bladder. Pain is the most intense, of course, which I don't know, of course, but anyway, pain is the most intense when the stone is moving or when the ureter is obstructed. Renal colic, as we said, this is what we call a severe pain, begins suddenly and is often described as unbearable, as we kind of hit on earlier. Some people describe it as worse than having a baby. They've had a baby. I can't imagine that, so that's pretty bad.
Pain is worse than moving or severe.
Yes, right. Yes, pain is most intense when the stone is moving or when it's in the ureter. Remember the picture I drew, how that urine backed up and it's trying to move through. Nausea and vomiting, pallor, and diaphoresis often accompany this pain. Very intense. Frequency and dysuria occur when a stone reaches the bladder. So the bladder is trying to get that stone out. So you'll see a lot of frequency and difficulty urinating when the stone reaches the bladder. Oligouria, small amount of urine, scant urine output, or anuria, absence of urine output, suggest obstruction, which is probably at the bladder neck or urethra. Oligouria, scant urine output, or anuria, absence of urine output, suggests obstruction, possibly at the bladder, neck, or urethra. Urinary tract obstruction is an emergency and must be treated immediately to preserve kidney function. Remember that picture I drew? Everything's backing up and into the kidney and causing kidney damage, renal damage. So what you're going to do is you're going to inspect the patient and check them for bladder distension. The patient may appear pale, ashen, and diaphoretic, and may be suffering from excruciating pain. Hematuria is common, and wait a minute. Right. Patient may appear pale, ashen, and diaphoretic, and may suffer from excruciating pain. Okay. Hematuria is common, and the blood in the urine may make the urine appear smoky or rusty. And this is from the stone-induced trauma moving through the ureter, bladder, or urethra. So as that one picture that Joey showed was that stone that was very, not smooth shaped, but very raggedly. You can imagine what that's doing to that ureter on the way down. Of course, that one was too big to pass. Okay. So a UA, urinalysis, may show white count, or WBC, excuse me, and bacteria due to the urine stasis, and we know that urine stasis causes urinary tract infections. Also, the serum CBC will show elevated white count, also indicative of infection. What you'll also see is an increased serum calcium, phosphate, or uric acid. And that indicates that there's excess of these minerals in the bloodstream and may contribute to the stone formation. So an increase in serum calcium, phosphate, or uric acid indicate the excess minerals are present and may contribute to the stone formation. So it may help you figure out what exactly the stones are made out of. Stones are very easily seen on x-rays. We do the standard KUB, kidney, ureter, bladder x-ray, or CT, or a renal ultrasound to further diagnose kidney stones.
Which stones are not opaque? Which ones are more opaque than the other ones?
I'm not sure. It didn't really talk about the description of it. Joey, do you know which ones are opaque?
No.
Yeah. Okay. All right, treatment. I'll try to look into that. Diagnostic findings, we're going to look at the UA, as we just talked about, the CBC, serum calcium, phosphorus, and uric acid. We also want the patient to catch any stones that they pass. So most patients, as I said earlier, can expel the stone without invasive procedures. Of course, the larger the stone and the higher up in the urinary tract it is, the less likely the patient will be able to pass it. So yeah, most patients can expel the stone without invasive procedures. However, larger stones that are higher up in the urinary tract are less likely to be able to be passed. And like I said, we want to capture that stone, so we strain all the urine. We have the patient strain all the urine. Again, hematuria is common. And again, blood may make the urine appear smoky or rusty from the stone-induced trauma, from the stone trying to move down through the ureter, bladder, or urethra. And we're looking at therapeutic management. Surgical interventions. Lithotripsy is our go-to procedure that we do for kidney stones that patients are unable to pass. What they do is they use sound, laser, or dry shock waves to break the stone into small fragments. And then we will have the patient strain all their urine after the procedure, and hopefully that has broken them up so the patient won't have as much difficulty passing them. We want to let our patients know that bruising on the flank of the affected side is very common and may last for a few days. Not to be shown. Yes, with the lithotripsy. There's also minimally invasive surgical procedures we can do. And stenting is a big thing. Man, I wish I'd invented stents. We can stent anything, can't we? So, stenting is where they put a small tube in the ureter by a ureteroscopy. So they put a small tube in place in the ureter by ureteroscopy. And what that does is that dilates the ureter and enlarges the passageway for the stone or stone fragments to pass through. And this prevents the stone from coming into contact with the ureteral mucosa, thereby reducing pain, bleeding, and infection risk, which also can block the ureter further. So the stent is put in and it dilates the ureter, enlarges the passageway for the stone or stone fragments, and this prevents, of course, the stone from coming into contact with the ureteral mucosa, and reduces the pain, bleeding, and infection risk that can happen with a stone moving through. Another procedure that can be done is retrograde ureteroscopy, or a ureteroscope is passed through the urethra. So it's a retrograde ureteroscopy. A ureteroscope is passed through the urethra and bladder and into the ureter. And this procedure has a device that the stone is removed by grasping it. It's a basket and forceps or loops to grab it. So it's a ureteroscope, is passed through the urethra and bladder into the ureter, and the stone is removed by grasping with basket, forceps, or loose. Another procedure, we got all kinds of procedures, is percutaneous ureteral lithotomy or nephrolithotomy. And this is the removal of a stone in the kidney or ureter through the skin. I've got a picture coming up. So they do a track through the skin into the kidney. Once a track on the skin is made, the kidney, there is an ultrasonic or laser lithotripter can be used through that to break up and remove the stone. Have any of you seen a nephrostomy tube in clinical? Okay. With this procedure, we often have, the patient often will come back with a nephrostomy tube. And so often the nephrostomy tube is left in place to prevent stone fragments from passing through the urinary tract. So it'll be on the outside of the body. This tube. Here we go. Do you need some? Okay.
Left in place for like how long?
I think it varies probably, but I'm thinking about a week. Any stories on nephrostomy tubes, Jody?
Got that.
Gotcha. Okay. Deanna looked something up for us. Thank you.
Deanna did?
Yeah. She gets the gold star. 90% of kidney stones are radio-opaque. Opacity depends on calcium content. Makes sense. Uric acid stones are radiolucent. So 90% of kidney stones are radio-opaque.
You can see through your gas better.
You can see them on the x-ray better.
Oh, okay. It's because of the calcium.
And the opacity depends on the calcium content. The more calcium, the better you're going to be able to see them on x-ray. Uric acid stones are radiolucent, so I guess they shine, kind of. Thank you very much. All righty. Any thoughts on nephrostomy tubes? No. Do you see them very often, Joey?
Not really.
No, not really. Okay. All right. Sometimes, of course, we just discussed or have discussed that some of the stones are too large, like the staghorn stone, to be removed, to pass through or be removed through any of these procedures. So we have to do an open surgical procedure. And we do that when the other stone removal attempts have failed or the risk for lasting injury to the ureter or kidney is possible. So if the doctor feels like it is just going to cause more damage, if they try to pass it, then they'll do an open ureter lithotomy, which is making an opening into the ureter. It could be a pylolithotomy, and that's into the kidney pelvis. or it could be a nephrolithotomy, which is into the kidney. And as I just said, these are used for the large impacted stones. Okay, so we want to teach our patients how to hopefully prevent further stones from developing. And so once we have them catch their stone, we will send it to the lab for analysis. And then we will be able to determine what dietary changes they need to do. And then again, consistent daily fluid intake. Like 3 liters per day or more to avoid dehydration and supersaturation.
As far as the behavior procedures go, so the lithotripsy is where no incision is made.
Correct.
It's kind of like foot, abdomen, and bruising.
Yes, depending on where the stone is. Yes, they just put it on the outside of the skin. Yes.
And then,
Yes.
and then the other.
And it's also the third most common cause of cancer death. Most colorectal cancers are adenocarcinomas. And these arise from the glandular epithelial tissue of the colon. So these arise from the glandular epithelial tissue of the colon. Most colorectal cancers are believed to arise from adenomatous, polyps. Big word. Adenomatous polyps.
What about?
Most colorectal cancers arise from adenomatous polyps. Yeah. So they start out as a polyp.
You don't have to spell it.
You sure? Okay. Adenocarcinoma. Adenomatous polyps. Okay. That present as a visible protrusion from the mucosal surface of the bowel. So, they're just these little protrusions. Colorectal cancers can metastasize by direct extension by spreading through the blood or lymph. Let me back up and say, if we can catch those before they turn to the cancerous kind of polyps, then we're okay. So that is, we're going to talk about screening for that. And that's why we want people to go in and get screened with a colonoscopy once they turn 50, at least the first time, and then they'll tell you if they get a polyp, you'll have to come back a little sooner. But if not, then they'll do it again in 10 years. So if we can catch it before it turns to cancer, you shouldn't have any problems. So that's why screening is so important. So these metastasize to the regional lymph nodes, and by direct extension by spreading through the blood also. The liver is the most common or frequent site of metastasis from circulatory spread. So we a lot of times see colon cancer metastasize to the liver through the circulatory system. It also can metastasize to the lungs brain, bones, and adrenal glands. So it also can metastasize to the lungs, brain, bones, and adrenal glands. But the most frequent site is the liver. So complications related to the increasing growth of the tumor include bowel obstruction or perforation as that tumor grows in size. And if we have obstruction with a perforation, it could result in peritonitis, abscess formation, and they can also develop fistulas. These fistulas can end up going towards the urinary bladder or vagina. So with the increase in the growth of the tumor, they're at risk of bowel obstruction or perforation. And with a perforation, you always worry about peritonitis, abscess formation, fistulas. The major risk factors are, it's most common in African Americans, greater than 50 years old, there is a genetic predisposition to colon cancer, colorectal cancer. Or if the person has had a personal or family history of the cancer and or diseases that predispose. What are the diseases that can predispose to that? It's Crohn's and ulcerative colitis, yeah. There's also what's called a familial adenomatous polyposis, which is FAP. And that is a strong family history of polyps that multiply and turn cancerous at a very young age, like 20-year-olds. So you want to know if you have a family history of that. Also, they found that some GI cancers are related to Helicobacter pylori or H. pylori, Streptococcus bovis, and JC virus, which I'm not familiar with. Okay. Ah, I can say it. We'll just call it JC virus.
What was the one before that?
Yeah, Streptococcus bovis. You heard of that one? Oh, bovis is Helicobacter. Okay, all kinds of good stuff. So we got H. pylori, Streptococcus bovis, JC virus, and human papillomavirus, HPV infections. Another good reason if our young daughters can get the vaccine, that's a good thing. Cause all kinds of problems, you know. Some other strong evidence of risk factors are long-term smoking. Smoking's just not a good thing, is it? If you haven't figured that out yet.
I'm a quick one.
Increased body fat, also we figured out. That's not a good thing. Yeah, that's all in trouble. Physical inactivity and heavy alcohol use.
Chad.
Told you so. Okay, so long-term smoking, increased body fat, physical inactivity, and heavy alcohol use. These are all things we probably hear about so many. I know. We're the worst, aren't we? Our health habits, especially in nursing school. Okay, some other ones which I know you're also have heard for other diseases is a high-fat diet. Yep. Particularly animal fats from red meats. I got any more steak. It's so sad. Love my red meat. Increases in bile acid secretion, which is from fatty foods, and anaerobic bacteria are thought to be carcinogenic within the bowel. So the increased bile acid secretion that we have with all this wonderful fatty food, red meats, and anaerobic bacteria are thought to be very carcinogenic in the bowel. Also, diets with large amounts of refined carbohydrates. They lack fiber because that food just sits there. And it should be, that's why we want high fiber. We want to move that stuff through so it can't decide to do bad things in our colon. Do you need me to go over those again? Mm-hmm. Okay. Long-term smoking. I know. Increased body fat. Physical inactivity. Heavy alcohol use. High-fat diet, particularly animal fat from red meat. And large amounts of refined carbohydrates that lack fiber. And decreased bowel transit time. Colon cancer and polyps. So this is just a picture of some of the areas in the colon that they can form. The ascending colon, transverse colon, descending colon, and sigmoid colon rectum. It's not a great picture, but here's a picture of a colon polyp. Signs and symptoms, what are we going to see? Rectal bleeding, not surprise anybody, right? Anemia and change in stool consistency or shape. The manifestations depend on the location of the tumor, which part of the colon they develop. However, the most common signs are rectal bleeding. So if it's in the ascending colon, it might be a lot darker than it's going to be a lot darker than it's going to be in the rectum area, colorectal area. So the most common signs are rectal bleeding, anemia, and a change in stool consistency or shape. So this patient might have poor constipation or diarrhea even. They talk about the stools looking like ribbon-like. They're very narrow because of the obstruction that's forming. Okay. Treatment. So we want to screen to try to prevent these polyps from turning into cancer or to detect the cancer earlier. So at age 50, you want to start, as we kind of hit on earlier, yearly fecal occult blood tests. And you can do these at home. You can send the patient from the doctor's office home with the 3 little cards with instructions, and they can do those and bring them back in. Also, starting at 50, you want to have colonoscopies every 10 years. And colonoscopy is definitely the definitive test for diagnosis of colon rectal cancer. They can see the whole colon, they can remove polyps, they can take biopsies, so it's just a really great screening tool because they can actually screen and take care of some problems or concerns before they become problems. Okay. Some of the surgeries you'll see done for colon cancer is the colon resection. And as the name implies, it's removal of the tumor and regional lymph nodes with reastomosis, which means they take out the cancerous part and then they put it back together. If they do a colectomy and remove all of the colon, the patient will have a colostomy. If they just take out part of the colon, it might be temporary, and we'll talk more about the next one. It's definitely going to be a permanent, but it could be temporary or permanent with this. Or an ileostomy, or an ilioanal pull-through. I won't expect you to know too much about that. I don't hear of those very often. The next surgery is more invasive, and it is the abdominal peritoneal, or AP, resection. And this is quite involved surgery, actually. So with this surgery, the surgeon removes the sigmoid colon, the rectum, and the anus through combined abdominal and perineal incisions. So this patient is definitely going to have a colostomy. You think it can be reversed?
No.
No. This patient is definitely going to have a permanent colostomy. Now, positive on colon resections is they're being done laparoscopically a lot. So that's, of course, minimally invasive surgery, so that's nice. So that makes recovery time much quicker. With radiation, it's really not done. Radiation is not done as a curative. It does provide some local and regional control of the disease, so with the thought of hoping to shrink the tumor and to control the cancer from spreading. Also, it's used as palliative measure to control pain, because if we're shrinking it, the patient's going to have less pain. Hemorrhage, also palliative for pain, hemorrhage, bowel obstruction, or Mets to the lung in advanced disease. So, just to try to keep that tumor from growing and causing further problems. And typically there is chemotherapy after surgery. And I'm not really having you know all the chemotherapy drugs for this. I know, we give a lot of medications on this. Okay, so depending on where the tumor is where the stoma or colostomy will be. So if the tumor is in the ascending colon, then it's going to be an ascending colostomy. Transverse colon typically over on this side. Descending and sigmoid colostomies are on high or low. So sigmoid colostomies are the most common permanent type of colostomy. And as we were just talking about, those are done when you do the abdominal perineal resection and remove the rectum and the anus. When they remove the rectum and the anus, they close the rectum. And but anyway, you've got to remember that that's another area you need to assess on your patient, not just the stoma and incision, but also the rectal area. As you can imagine, that takes a long time to heal, and they can have a lot of drainage from there. So it's something to really assess on our patients. The stoma is formed from the proximal sigmoid colon, and usually in the left lower quadrant, when the anal canal is closed after a sigmoid colon, rectum, and anus is removed. Temporary colostomies are usually reversed in 3 to 6 months after they are formed. Does anyone know what that's called when they have that colostomy reconnected, or the valve reconnected?
The takedown.
Takedown. Yeah, takedown. What's
Resection.
they call it a takedown when they bring that. You know, it makes sense, doesn't it? They're taking down that part of the valve and then reconnecting. Yeah.
You say 3 to 6 months?
Yes. Mm-hmm. Yep, 3 to 6 months. Hopefully.
I have one of those ones.
Going back the other way. Okay. Another type of colostomy you might see, which I have not seen too many of these. Have you, Miss Hyde, seen too many of these double barrel colostomies? Not too many?
Not lately.
Yeah. So then there's two stomas. There's a proximal stoma and a distal stoma. And these are called double barrel stomas also. And there's another name for them. Yes.
Why would you ever have a temporary colostomy? I always thought when you got it, to let it rest.
They let it
Exactly. It's to give the bowel rest to heal.
Like all surgeries, like all bowel surgeries.
If the reason for doing the colostomy is to let that part of the bowel below it heal, like with ulcerative colitis, Crohn's. But if you take out the rectum, and I'm not sure you don't really always have to take out the rectum and close the anus for it to be permanent. It just depends on how much colon is left. But yes, they can do temporarily for healing to happen. Yes.
My mom had her colon removed, but they thought her small.
Okay. Okay.
They reconnected her using her small parts. She had ulcerative.
Okay. So J pouch, if you've heard of it, in an emergency for intestinal obstruction or perforation, because it can be created quickly. Like I said, there's two stomas. The proximal one, closest to the small intestine, drains the feces. The distal one does not. It just drains mucus. This is temporary, but I guess it could be permanent, but typically temporary. Okay, with our stomas, and we kind of hit on this earlier, but I just want to reiterate because I think it's an important part of your assessment when you're taking care of patients with stomas, that you assess the color and the integrity of the stoma frequently. Healthy stoma should be reddish pink and moist and protrude about 3/4 inch, 2 centimeters from the abdominal wall.
3/4 inch.
Now, initially post-op, it might be a little edematous, but they tend to get smaller. It's not unusual to see a small amount of bleeding at the stoma right after surgery. But the things you want to report when you're looking at stomas and colostomies are, of course, we talked about a little bit, we'll talk about it again, signs of ischemia, not getting good blood supply, and necrosis. What's that going to look like? Dark red, purplish, or black color. So signs of ischemia. Dark red, purplish, or black color. It should not be dry. It's a mucous membrane, so it should be moist. And if it's firm or flaccid. So it shouldn't be dark red, purplish, or black. It should not be dry, firm, or flaccid. Unusual bleeding. Cutaneous separation. Okay, mucocutaneous separation, which is breakdown of the suture line securing the stoma to the abdominal wall. So basically your incision's open. And also you want to be really careful, and I know Amanda came and talked about scare of stomas and colostomies. You want to make sure you really assess the skin around the stoma frequently and check the pouch system for proper fit and signs of leakage. So the skin should be intact, smooth, without redness or excoriation. And usually the colostomy will start working about 2 to 4 days post-op. Yes. You start functioning, excreting stool. 2 to 4 days post-op. As I hit on a little bit earlier, monitoring the drainage from the perineal wound is really important, and the cavity, because of the possibility of infection and abscess formation. It's really normal to see serosanguinous drainage from this area, and it actually might last for 1 to 2 months after surgery. It's normal to see serosanguinous drainage from the perineal wound, which is where the rectum was. And this may be present for 1 to 2 months after surgery. And it takes about 6 to 8 months for complete healing of this area to occur. Sometimes this wound they have more discomfort with this wound than they do the incision, and that makes sense to me. So what kind of interventions do you think would work good for us?
Ice bath or yeah.
Sitz bath, that's what I was thinking.
Yeah.
Sitz baths, they didn't say anything about ice packs. Not sure you couldn't, but the warmth will help with the healing. They tend to have a lot of itching in the area, so they also will order benzocaine, and that also helps to numb the area also for pain. What we want to do with our patients is we want to be comfortable with colostomies, right? And I think the more you work with colostomies, the more comfortable you feel with them, but we want to include our patient in the care of the colostomy because this is something they're going to have to work with for a limited time or maybe for the rest of their lives. So it's really important to have them participate in the colostomy care when you start it. And this helps restore the patient's sense of control over his or her lifestyle and also facilitates improvement with self-esteem. And of course, they have a lot of feelings about surgery like this and diagnosis like this. So you want to encourage them to verbalize their feelings and, verbalize their fears and hopefully troubleshoot what they can maybe do. What's great is they have such good support systems, ostomy support systems, and they have people come in usually before someone's going to have a colostomy and tell them, talk to them and tell them about their experiences. We have ostomy nurses in the hospital, and they'll come in and the doctor will tell them where they think the tumor is. Well, they probably know pretty much where the tumor is. And so then the ostomy nurse will pick out a lot of times where to put the stoma, where it won't, be in right where your pants hit or in a crease, that kind of thing. So we got our pink. So prostate cancer is an abnormal growth of prostate tissue, very much like BPH, but not in a benign way. So prostate cancer is one of the most common types of cancer in men, in the world, in the whole world. Yep. I don't know. That's not fair. Men older than 65 have the greatest risk. So, 65. It's one of the most common cancers in men in the world. And men older than 65 years have the greatest risk. In the U.S., it affects African American men more. We're African American. We're getting picked on today, aren't they? More commonly than Euro American men. And also at an earlier age. And it talked about in your book, and we've got to keep this in mind, that they get it earlier, and they also, so possibly it's a healthcare issue that they're not, it's developing into cancer, and they're not living as long. So what's wrong? What are we not getting them healthcare?
That primary.
Yeah,
Right.
screening.
Right, screening and all that kind of stuff. So I didn't word that word. Okay, most of these are adenocarcinomas and arise from the epithelial cells located in the posterior lobe or the outer portion of the gland. The good thing about prostate cancer is very slow growing. And it metastasizes in a predictable pattern. So it's slow growing and metastasizes in a predictable pattern. So, common sites of metastasis are the nearby lymph nodes, bones, lungs, and liver, especially the bones of the pelvis and the sacrum and the lumbar spine. So it's slow growing, metastasizes in a predictable pattern, and the common sites are nearby lymph nodes, bones, lungs, and liver. The bones of the pelvis, sacrum, and lumbar spine are the most often affected. Proximity, right? Prostate cancer is likely caused by a number of factors, including those androgens, those male hormones. Here we go again with the dietary factors. No red meat, I'm going to say, such as eating a diet high in animal fat, red meat, and complex carbohydrates or having a low fiber intake increase the risk. Men who have had a vasectomy or or exposed to environmental toxins such as arsenic may also be at increased risk. So men who have had a vasectomy or exposed to environmental toxins such as arsenic may also be at increased risk. So the signs and symptoms, they're very similar to BPH. So the first symptoms are related to outlet obstruction, urinary, such as difficulty starting urination, frequent bladder infections because that prostate's enlarged with cancer, so that bladder is sitting in that urine is sitting in the bladder, and urinary retention, very much like BPH, cannot get that urine through. Also frequency, hematuria, nocturia, and pain with intercourse, especially with ejaculation. What's interesting is many men on autopsies, it's found that they have prostate cancer. So many men die with prostate cancer. So sometimes doctors will discuss, forget the term they use, but watching it, because it's so slow growing, that they'll just watch it and, keep check on it, weigh the options, or whether it's going to cause any problems in their life, or will they die before it's going to be causing any problems. Okay, so how do we screen for this? The same way we do with BPH. Do a digital rectal exam, and what will we find, or what will they find?
A stony
Right.
Stony heart, prostate.
Stony irregular nodule in it within the prostate. Okay. And the PSA is used in conjunction with the digital rectal exam, and it helps detect cancer in men 50 years or older. It's not a positive indication of prostate cancer, but they still use it. It can also be due to BPH. It can be a little higher. But with prostate cancer, it's really high. And they didn't really specify how high really high is. But they do use it. They use it a lot after surgery. They want to see those numbers coming down. So that's the way they use it, but it's really not used to, for sure say that they've got prostate cancer.
Oh, what's the DRE?
Digital rectal exam. They can also do a transrectal ultrasound. If the PSA is elevated, and this is a small probe that they insert in the rectum, and it provides a picture of the prostate. This is also used to help guide the physician to insert a needle into the prostate gland and remove a tissue sample. The most common surgery is laparoscopic. Don't we love our laparoscopic surgery? They can do a laparoscopic radical prostatectomy. A radical prostatectomy involves the removal of and you know what radical stands for, right? Taking a lot of stuff out, right? The prostate capsule, the seminal vesicles, the cup at the bladder neck, and regional lymph nodes. So with a radical prostatectomy, they take out the prostate capsule, seminal vesicles, cup at the bladder neck, and regional lymph nodes.
Do we have to know every single thing that's taken out, or can I just say, with this problem, this is the surgery you do? Thank you. I just want to make sure that I'm studying and
Well,
don't.
I don't think I'll ask you a question that you won't be able to answer.
Take a lot out.
Yes.
Take everything.
Radical is taking a lot of stuff out. Yeah. An open radical can also be done. And it can be done transperineal or rectopubic. And those are the most commonly used open radicals. The retropubic, the good thing about that is it's nerve sparing for the patient. The retropubic allows the surgeon to visualize the prostate and bladder neck better. And so he can control the bleeding and have access to the pelvic lymph nodes. So retropubic allows the surgeon to visualize the prostate and bladder neck better so as to control bleeding and have access to the pelvic lymph nodes. They sometimes use radiation. This can be external or internal. And external is pretty self-explanatory. This side will love this. The internal is brachytherapy. That was a board question or something that a lot of people miss. So remember this one. So brachytherapy, put this in your file, is low dose internal radiation. And this is by radiation that's implanted. And it's low dose radiation seeds that are implanted directly into and around the prostate gland. So it's low dose radiation seeds that are directly implanted around the prostate gland. This can be done outpatient. The good thing about this is the patient's dose of radiation is so low that it will not cause a hazard to himself or others, so they can go home. Didn't mention any. Then there's also androgen deprivation therapy. Androgen deprivation therapy blocks the body's ability to use the available androgens. Sometimes the metastatic cancers feed off these, so these drugs are used for metastatic disease. So they block the body's ability to use available androgens. Another surgery they can do is an orchiectomy. And this is removal of the testicles. Yeah, that's pretty radical, isn't it? Which will also induce androgen deprivation. So anything to keep those naughty androgens, male hormones, out of circulation. just kind of an anatomy picture of where the bladder is with relation to the seminal vesicle, prostate gland, tumor, urethra, and what's left after the prostate gland and seminal vesicles are removed. What they do is they reattach the bladder to the urethra. So once they take all that out, they attach it back to the bladder, the urethra to the bladder. Complications after this surgery can be erectile dysfunction and urinary incontinence. These are very common after the radical prostatectomy. Makes sense, doesn't it? Because they've taken out a lot of organs. So ED and urinary incontinence are common long-term problems after an open radical prostatectomy. The other surgeries, it's not as definitive that they're going to have these problems. We hope they're not. Again, we're going to use those Kegel exercises, so we need to teach our patients about that to help with the incontinence. It may not totally alleviate it, but it should help. If they end up with a urethral stricture, they would need surgical intervention. So there can be damage to the urethra where there's scar tissue that forms, and then they have to have that surgically taken care of. Our last exemplar is erectile dysfunction. Guys get picked on this unit, though. Also referred to as ED. And there's two types. Organic, which is a gradual deterioration of function. And functional, which is a psychological cause. Comes on sudden, and a lot of times it's due to high stress. What erectile dysfunction is the inability to achieve or maintain an erection firm enough for sexual intercourse. Inability to achieve or maintain an erection firm enough for sexual intercourse. With organic, it's a gradual deterioration of function. The man may first notice diminishing firmness and a decrease in frequency of erections. Why can this happen, or why does this happen? It could be inflammation of the prostate, urethra, or seminal vesicles. It could be because they had a prostatectomy, or lumbosacral injury, lumbar sacral injury. Vascular disease can also be a factor. So hypertension can cause this. Not getting good blood supply. Chronic neurological problems, such as Parkinson's, endocrine disorders, due to, for example, diabetes mellitus, smoking. Got smoking again. Nobody's going to smoke after this one, right? They should have. Now y'all have to graduate. Or alcohol. No smoking and drinking, yeah. And there's certain antihypertensives, I know you guys have looked up, that cause ED. beta blockers, ACE inhibitors, and just generalized poor health. Functional problems are episodes of ED. How they test this is these patients will have normal nocturnal and AM erections. The signs and symptoms appear suddenly and are preceded by periods of high stress. Treatment. Sometimes it could be that it's a low testosterone level. Could be the gonadotropin levels are low, the LH. They can also do a duplex Doppler ultrasound, and that will look at the vascular area to see if it's a vascular issue. And then they will do, they can also do a penile monitoring through sleep studies or home monitoring. Okay, so I know you guys have seen all the commercials on these. Medications. What's the important thing you want to tell the patients when they're on these medications?
More than 4 hours.
You're not going to miss any of these questions, are you? What medication do we not want them to take? We want to make sure. Because what does this do? It's a...
Yeah.
Okay. Nitrates. All right. Don't take nitrates. It has vasodilation, and so do these medications. So this patient could pass out. So the medications, as I know you've heard, Levitra, Cialis, Viagra, they also have injectable hormones, such as papaverine and alprostadil. That's a great way to end, isn't it? They have some mechanical devices that can help. Okay. You gotta help these that can help. You guys need to get a laugh about now. Vacuum constriction devices. And I'll just quickly tell you what those are about, unless you want to just read about it. But how they work is, you can imagine. Okay, they draw the blood into the penis, trapping it there with the constricting band. The device is removed for intercourse, except for a small band called the O-ring, which is left to maintain the erection. So now if you hear about it, you'll know what this is all about, right? Yes. You hear Ms. Hyde, it's like a gasket on a valve. So the little ring stays on there. All right, one more. Uh-oh, we missed one. Probably good we missed it, huh? All right, one other place we're going to talk about, surgery. And I know we've had some patients come through with these. So there are prosthetic devices that can be implanted, and they will inflate. They're, internally implanted. They have pumps that are located in the scrotum, and the scrotum is kind of like a reservoir for the fluid, and the fluid fills a cylinder within the penis to achieve the erection, and then there is a release valve that transfers the fluid back to the reservoir. Yeah. So, in other words, there's a prosthesis in there. The patient can pump up